And in answer to links in quite nicely with your two questions, how do we, if we have a startup and we want to link into healthcare organizations, how can we do it? Well, there are many academic healthcare science networks now throughout the UK that are doing just that. They're linking academics and industry and clinical needs together. And I'm currently working on one with UCH, University College London Hospitals, where Luke O'Shea is going to talk to you today. He's the Director of Innovation there. And having now worked firsthand with his team, my word, they've got a vision, and I'm really looking forward to hearing it. Thank you.
Thank you so much. It's so fantastic to be here today. Thank you for being here rather than at COP. I know maybe you didn't have a private jet available, but anyway, it is much appreciated, and thank you for what you're doing. I think there's this, we were just talking earlier about striking this balance between knowing things are getting better, this is all achievable, we can absolutely do it, and also the sort of the sheer gravity of it and the sort of, my goodness, this does seem impossible as well. So we've been trying to chart our path through that. This is us, trying to make a little difference, one solar panel at a time, one giant pair of blue gloves less at a time. It's a real privilege. I think it's I was talking to my daughter about this yesterday. I was really worried. Everyone was very worried about climate, and I was just saying, look at the change that has happened in so many fields. The revolution, and by 2030, we'll be. In fact, there have been plenty of days in the UK where the majority of our power is powered by renewables. The electric vehicle revolution, all of these things coming forward. And, it's easy to focus on the negatives, but there are some extraordinary opportunities too, and I hope we'll capture some of that. But not before we obviously remind ourselves that actually, it's a difficult situation we're in. I'm not going to rehearse this for you because you really do know all of this stuff. We're going to have another one of the hottest years on record. I'm pretty sure, given how September was off the charts here, and I haven't got the later months from Berkeley Health data, but it's quite possible we might have our first 1.5 degrees C above baseline year this year globally. It's a serious year. That could be an anomaly. There's a lot to think about whether that's absolutely correct or not. But it's very difficult when you look at this chart not to see a pattern anyway. And my daughter also corrected me on this slide because I had been talking about the melting of the Greenland Arctic shelf, and she said, well, actually, why have you got the Arctic sea ice melt there as well? That's not actually raising sea levels, Dad. And I'm like, oh yeah, good point. So, but the Greenland, well, the point is, I suppose, taking a step back, leaving aside the shrinkage of the of sea ice, the Greenland, obviously Greenland above any of the ice above the rock, we don't really know what the tipping point is. There's some really kind of good papers out there. I'm sure a few of you have delved into them, saying, well, at what point do things get, take a different step, whether it's the, Siberian permafrost or whether it's the Greenland shelf or whatever. And, there might be red papers that say 1.8 to, this is a serious thing. And when are we going to reach that? Well, it's looking pretty soon. It's, we're talking within the decade probably. So we've got our work cut out. I was thinking about this. I don't know. Did any of you watch any of you? I have a sort of morbid fascination with the COVID inquiry. It's probably just me. Anyone's watching it, but and Matt Hancock up last week and various things I've been watching, and I was just thinking, what they're obviously retelling the story. What will the history books say about how well we handled COVID and all the rest of it? And there's really interesting parallels, and I think this is pretty blindingly obvious, but the scientists raised the alarm. They could see the trajectories. They said what needed to be done, and we were in a hospital where we quadrupled our intensive care beds. We opened a new ward, a HDU ward, to cover our patients who were just below or coming out of a step up, step down of intensive care, and we completely reconfigured everything. And we were like, well, this isn't going to be enough. And it seems very obvious from a climate point of view exactly what has to be done and the kind of mitigations that will get more and more complex and get put in place. And I was just thinking, you know, what is the story? We'll be looking back in 10 years' time, 20 years' time, and say, well, what is the story we actually want to tell? You know, in front of the, you know, whether it's in the history books or the inquiries or whatever. And I just remember, because I mean, it was so desperate that they had me working on the wards. So I was doing family liaison, I was filming. I was phoning the families, saying what was happening, because they couldn't come in, of course. And I was doing video calls with their families, some of whom couldn't speak, of course. They had the CPAP on or whatever it was. And it was, I mean, it was pretty difficult time. And I remember there's one guy who I just can't get out of my head. And I was talking to his son on the phone, and he said, yeah, he caught COVID the day before the restrictions came in. And I sat with that guy, and he died, unfortunately. And I just can't think, you know, maybe if it had been a day earlier that the restrictions had come in, maybe he wouldn't have died. Who knows? But it's quite a salutary lesson, really. You know, at what point do we say, yeah? And it's not easy, you know. Of course, we're going to loads of people out there going to say scientists are wrong. Well, I don't think anyone in this room is going to say that, but as you're here, or, you know, this is too difficult, or it's too expensive, or, oh, we've got plenty of time, or, well, you know, don't worry about it, we'll get it done. So it just is important, I think, that we all think, you know, what is the story we want to tell? What I was asked to talk about is what we've been doing, and it's a very positive story, I hope, but there's a lot to do, and it's difficult. It's really difficult. I think the thing is that in the NHS, I don't know about any of you, but there's an awful lot of documents out there, and not all of them are really great strategies. They don't necessarily say, they say, oh, really, you know, lovely things about what needs to happen. You know, oh, we need to become a world-class research institute, or da-da-da-da-da. But are we clear about the diagnosis? Are we clear? Are we really precise about our objectives of what we're trying to do in our local plans, in our national plans? Are we really coherent about the steps of actions to get there and what is going to be needed resource-wise? Just be honest about that, and not just, you know, something that says this is important goals and, right, okay, we'll worry about actually how to get there later. So that's what we've been grappling with, and we haven't got it all right. But this is our strategy we published this year, Critical Care for Our Climate, which tries, and we've been working to get the action planning detail behind it, tries to outline some of that. So diagnosis, you all know about the global impact. I'm not going to rehearse that. First, do no harm. We're a big deal, you know, across there, more than aviation, more than many, many sectors. And we also know, and you know from the earlier presentations about the health impacts of this, the health impacts affecting, you know, we've got thousands of heat deaths last year. We had theatres, diagnostics closed down, all of this stuff that's happening now, as well as the, there's a really interesting paper in Nature, if you're, about the increasing risk of cross-species viral transmission. It's, you know, another link back to the increased risk of pandemics as a result of climate change. There's so many things that are, you know, linking things back, rooting it back to health. And you've already had a lesson on scope 1, 2, and 3, so I won't go over that. But you take these big picture things, then of course every institution, every organisation needs to say, well, does that fit with what we're doing, right? And actually, there's a big difference between the pie chart that Sarah put up and the pie chart that we've got for our hospital. First of all, the direct emissions are much smaller as a relative proportion of the pie. And within that as well, the big ticket thing for us is energy. It's basically getting off gas, and I would be very surprised if that were different for any other big acute like us. Obviously, travel and fleet, anaesthetic gases, yes, absolutely. But then you look at supply chain, 3/4, you know, it's a huge deal. And so the things that Sarah was talking about signalling to our providers. So I've been having an argument with Epic, our supplier of our EHR, about when they're going to publish their their carbon footprint when they're going to publish their targets. They're not at the moment, and their chief executive is ignoring me. But you know, that's a big company, multi-billion-pound company that can. I think it's got 2 billion income a year, something like that. It's a big deal. It could certainly work out its carbon footprint. And it's not doing it. So there's a lot to do in this bit. And obviously, you know, medicines and chemicals, which we already talked about, is more than our entire direct footprint, basically. What we've tried to do as well in this diagnostic bit of the strategy is, and this has been hard, is really just starting to track year on year what's happening. And I mean, we've had a lot of data validation issues, and it's a bit boring, but the long and the short of it is we managed to get, within a couple of years, our anaesthetic gases down by 2/3, which is, you know, is fantastic, and that has made a massive impact. That's over a ton of CO2 equivalent. But we've opened 2 hospitals in the meantime, and our electricity has gone up. But I would say what it has given us is the data to understand in those new hospitals, why is it, what's going on. Actually, we are using a lot more gas in our newest hospital than we thought. We've also got a particle accelerator in there, which is using a lot of electricity for a proton beam, but actually it's more than we thought. So we've then gone back to our providers. We had to look at, are we actually set up as we thought in terms of our hospital? So, you know, the diagnostic bit of the strategy is so important. You can take those big pie charts that we said at the beginning, but you need to understand your own pie. We set targets, as everyone did. We ahead of the greener NHS targets, like lots of people. We're really trying to push ourselves, and we honestly don't know how we're going to get off gas by this point. It's a really serious issue because of our estate, but we're working out, and like everyone else, we're applying for PSDS funding and everything else to try and do this. Oh, fall off, that would be good. But I was also just going to say, we were quite obsessed with these timescales, but if I really try to get our team to think of it more like a budget, right? What's the total budget that we've got to stay within 1.5? And if we can get a ton off our anaesthetic footprint now, then that's a ton less every single year, you know, going up into the atmosphere. It adds up to an extraordinary amount. It's like SIP, or non-recurrent SIP versus one-off dodgy sort of payments. That's obviously a joke that none of you are interested in. That's fine. Nice hospital target joke. But anyway, yeah. So think of it as a budget. As much as anything, the more that we can do now, the bigger the impact we have longer term. And that's an obvious point, but we shouldn't get too fixated on the dates, but they're really good for giving a bit of focus. Our programme covers all the things that you'd really expect: direct emissions around estates, etc. Supply chain, 3/4, remember. But we've got to bring people with us, right? I mean, I'm preaching to the choir here. We've got to bring people from all around to think this is actually a serious issue. This is a priority, just in the way that we all galvanised around COVID. And also, we've got to completely rethink clinical models. So I'll just reflect on that a bit. So we've got, this year, we've got our individual projects underneath that. So, you know, we've got to get our heat decarbonisation plans in place. PSDS bids went off, and then they told us that they'd mucked up the IT, so we had to do it again with 6 people around computers trying to get it off. It was like Taylor Swift tickets. It was very exciting, or I don't know if that's the audience. I might get the wrong audience. Glastonbury tickets. But anyway, this is apparently how government capital is allocated. You just basically go into some kind of weird lottery, and if you happen to have a team of people that can do it in 5 minutes, then you've got a chance of getting some capital. Anyway, sorry, that's estate, so lots in estates, because that's really, you know, a big focus, and also an area where we can save an awful lot of money, and we have on things like LED lights and all of that. Massive return investment, solar panels, etc., etc. That's all good stuff, easy in some areas, impossibly complicated in other areas like gas. Lots around supply chain, as well as some very visible things we've talked about, and indeed Sarah showed off, you know, things like it's been fun engaging wards and stuff that they can get involved in. You know, all the surgeons and anaesthetists love having their reusable you know, hats or whatever. It's all, you know, all good stuff, visible things that we can get going on now, as well as harassing Epic to say, come on, pull your finger out. Low carbon care models. The thing is that we need to shift the thinking about climate just into really align it very closely with a number of other key areas that we've got to push on and that we're all working on, and that's including productivity. The thing I always tell people is, just start with looking for where the waste is. That's waste carbon as well. For every unfilled theatre list, for every, DNA at clinic, whatever it is, that's absolutely a fixed carbon cost as well as a fixed a price. So follow the money, But, and then what's the pathway look like? What's the difference? We've talked about virtual. I'm unashamedly pro-virtual, but we have to get better at doing it well. So this is us. We deliver I think probably more virtual appointments, about 400,000 than any other trusts, and it works quite well. But you need to obviously bring the, things like the video technology with you, and you need to update, and you need to include new forms of communication with patients, pre-clinic questionnaires, all of these things which together can deliver a much higher quality outpatient appointment. Celebrating the stuff that's going on. You see us with our nitrous destruction units here, and small things, really get people excited, but actually just going out there. And every time you get a project that's delivered, shout about it, because what you're trying to do as well is create a momentum across the organization where people really know that it's actually, it's okay to get on and to spend time doing this when there's so much else to do. We do an awful lot of communications, even though it takes quite a bit of time. We've spent a lot of time with the exec lead on sustainability, spend a lot of time with the board, focusing them on this. We've got a great central team. As Johnny said, you have no problem recruiting the most unbelievable people to a sustainability team. It's absolutely staggering. For every advert we put out, even for like a year, we get 100 people, many of whom are extraordinary. So yeah, this is a great area where you can get a lot of bang for buck. Okay, I'm nearly finished. So you have to remain hopeful on all of this stuff, right? How do you keep telling people that that yes, this is really hard. Looks impossible at the moment, but absolutely all is not lost. And the thing I really am, astonished by is the genuine exponential rise in key technology areas. So it's not year on year we're seeing, a steady rise in batteries and renewables and EVs. We're seeing an extraordinary curve, a bit like a pandemic, going up. And it's not. That gives me hope that, by 2030, a lot of things that seem niche now will be absolutely the norm, and are, of course, in renewables, of course, the cheapest form of energy now. Deforestation arresting in many areas, big businesses being incredibly ambitious in most areas. People are changing. This is a big deal. So lots of reasons for hope, and reasons to put your plan together. We do a lot with our staff, our 200 plus sustainability champions in our network. This is also about making the use of what everyone else is doing, the networks, the brilliant tools that are available from Greener NHS and others that enable you to oh well, they did it over here, right? Let's get on, let's deliver it. But you need the resource, you need the team, of course, to do that. And we got the team because we delivered about £2 million worth of savings as a result of some of the early programs. So it is possible to do this. Yes, there we go. Another plug, Future NHS, all of these tools are out there. So we've tried to really think about how we're going to get there, what the big blockers are, and focus our program around that year on year. It's not easy. And we know that that there are, some very significant challenges that probably won't be solved without major government intervention. But this is something that is so exciting, that people feel so proud to be a part of, that is so empowering, that adds to retention, that does that people want to get up in the morning and be a part of. So it really is a fantastic program to work on. And there we go, Mandela quote, obligatory. It always seems impossible until it's done. And I think that is the case. You know, COVID seemed impossible and we managed to get through it. All of these things seem impossible, but we absolutely will get there. That's enough for me. Thank you.
Thank you very much, Luke. That was absolutely fantastic. I think we'll have some questions now, if that's all right with you. Does that work with you? Anyone got any questions for Luke? Fantastic.
Brilliant, and thank you very much for that. That was incredibly interesting. For people working in sort of your role, talking about the issue of health and climate, obviously there's the massive sort of decarbonisation focus, which we've sort of spoken about so far, but also the actual link between that and health outcomes. In your role, how much time do you split between adaptation and resilience, which obviously featured on your sort of roadmap, versus decarbonisation? And how do you sort of look at that in terms of cost and sort of patient care as well? What's that sort of split in your thinking and what you think is important on this topic?
It's a great question. So it's about the resilience and adaptation. And I think most trusts like us are a bit behind the curve on resilience and adaptation. And you'll see in HSJ in the summer, you know, someone's data center has exploded, or the diagnostic machines are down, and there's a flood in, you know, a hospital or whatever it is. And it's an area that we have had big discussions of our board and exec level, because it's a very real problem for a lot of big trusts, especially with the state, as most people have, that it's a bit aging. I would say it's a really, really small part, and it should be a much bigger part of what people do. You know, we had a debate last week at the exec about, you know, where it should sit on the risk register and what we were doing about it. The only thing I say is that a lot of this is sort of bread and butter in many areas to our operational managers, and they're incredibly good and creative at solving short-term problems like this. What we're less good is doing mending, sort of sticking plaster solutions. But there needs to be much, much more thought about, about the long-term adaptation of buildings and things, and indeed even the basic design standards. So a lot more to do. Probably not enough, I think. And I wouldn't be alone. But we are talking about it, and actually, you know, there's a lot of good work that goes on at operational level on that.
Hi, thanks much for your talk. It's really inspiring to see what we can do day to day. I have two quick questions, if you don't mind. First one is, is there any advice you can give on how to deal with companies that don't want to give their targets, a bit like Epic, or like Sarah mentioned, we want all companies to provide their net zero targets, but that doesn't mean they actually have to follow that. There's a bit like the COP thing that's been going on. A target doesn't really mean much if you're not doing anything about it. And then part two is, do you have any advice in getting the infection control team on board with reusables?
Yeah, two good questions. Well, it's the first step, isn't it? Getting complete transparency. It is embarrassing, I think, for a lot of companies when they do publish their data. And if they're being scrutinized, obviously, through procurement processes, and, you know, for a big electronic health record, you are going to, I'm talking to other trusts that are doing this at the moment with Epic and Cerner, and it should be part of the discussion. And so I think it makes a big difference, and it will show them certainly where on, you know, basic easy scope 1 wins around things like electricity and stuff, they could move quickly with a business benefit. So I remain reasonably hopeful. I suspect the reason Epic aren't that interested in some ways is not because the Epic team aren't that interested, but because of some of the polarized American politics on this. That's my guess. I don't know. So I would say it's a really, really important first step. It's a bit like, you know, publishing accounts or whatever. Doesn't mean that people are going to get really good at productivity just because they publish their accounts, but actually at least you can see what's going on and you can make judgments as to whether you engage with them. The other question was completely different, and I've completely forgotten it. Infection control, yeah. Actually, this has been an interesting one. Again, I think there are a lot of areas where we found people in our infection control team who are really passionate about this agenda, and maybe not necessarily always going in at the top, but building those relationships where you find someone who's the sustainability champion, and then using those people as a link in. I find that the bigger issue, rather than positivity about some of this stuff, is just the capacity, is just getting them to agree and sign off, and I think that's probably the bigger barrier, is not a lack of willingness in almost all areas, be it medicines, estates, whatever. It's really about kind of the capacity to both engage and then to spend the time to deliver as well with us, walking alongside. So, but yeah, I mean, I can put you in touch with if you have with the supply chain lead in our team, who's an absolute genius at getting IPC people to come on board on reusables.
I'll be taking those details myself as well. Thank you very much, Luke.
Okay, thanks very much.
That's brilliant. If you can get IPC on board for any of your projects, those are the real drivers.